Hello, my name is Jalen Avila. Now, I know that over the past, I don't know, probably year, my appearance has been, I guess, shifting a little bit. It's actually a big thing happened recently that I'm very excited to I guess, share with everybody. It's something that I've felt inside that I basically have been needing to do since as early as I can remember. I didn't really have the ability to do it. Really didn't have the language for it. And with the help of very supportive family and very supportive friends, I'm finally able to do the thing that I've always needed to do but couldn't. And I'm very happy to share with you all that I recently got a nose ring. I only cried a little bit out of like one eye, um, and I'm transgender. Um, I'm gonna do a post about it a bit later, just like I guess sharing a little bit more about my journey. But I kind of need to collect my thoughts and kind of, I guess, figure out the best way to share that appropriately. But before that, I wanted to share with you all a lecture that I gave that I actually am very excited to have given it. I was asked to speak at SEMPA, which is the best conference, is at least the best PA conference I've ever been to, maybe even the best conference in general I've ever been to. But the year's not out, so I can't really like say that yet. But so far, probably the best conference I've been to this year. Thanks so much, Fred Wu, for inviting me. It was so great catching up. I gave a lecture there called Extreme Ultrasound Cases, which is basically my five favorite cases over the past about a year. Now, these cases are just it was hard because there's so much good stuff. There's so much good stuff, and it was really hard to kind of try to distill it to the five most high yield cases. I definitely have some kind of like amazing critical care type stuff, but then I have been doing a lot more MSK stuff, and I included a couple of cases of that of near misses and ways that ultrasound dramatically changed management on our patients that we see in the emergency department. And I'm very excited to share it with you here. I just re recorded it for a group of my residents where I work at Temecula Valley Hospital in Temecula, California. And stoked to share it with you all. So without further ado, here is Extreme Ultrasound Cases. All right. So, what we're going to talk about is some extreme ultrasound cases. I actually gave this at the PA American College of Emergency Physicians section. So, it was basically like the national meeting for PAs or one of them. And it's so happy to give it. It was actually in Louisville last week. There was a kind of a lot going on. So, I like to try and like record these lectures kind of like as I go, but I didn't get around to it, unfortunately. But it's great because now we're going to talk about it here. So what we're going to talk about today is I'm going to go through just five cases, and with each of those cases, I'm going to just go through some kind of pro tips, some like extra things on top of that. This is the reason why I kind of like it, because I don't have to like focus on one thing. It's like I can give you little fun things about everything. All right. So our first case, we have a 65-year-old female, and she presents as a transfer from an outside hospital as a STEMI, where we work, as you all know, in Temecula Valley Hospital, although the group is called like Southwest Healthcare or something like that. But in any case, it's a hospital in Temecula. And they got transferred. We're a STEMI center, and it was STEMI. The cardiologist looked at the EKG, and he's like, yeah, we'll just go ahead and activate the cath lab. And this was the EKG. Now, I'm looking at this EKG and I don't know, it doesn't seem like the most typical EKG, but I'm down, for a STEMI. If we look at these inferior leads right here, 2, 3, and AVF, we can see that, yeah, I'd call these ST elevations for sure. I'm also seeing one right here. I'm seeing, so one's elevated. I'm seeing elevation in V5, V4, maybe V6, kind of all over. Depression in AVR, which would be consistent with like a high lateral, and then maybe some depression here in V1. So, you know what? If I saw this in the field and I didn't really know anything else, I would have called it STEMI too. Now, one of the things that I'm kind of like trying to focus in on a little bit more is to work on my regional wall motion abnormality identification. And this is actually something that is important for multiple reasons. The first one that I can think of is in the setting of an arrest or a peri-arresting patient. And in those patients, there's a lot going on, and you might not be able to like sit there and get that EKG exactly when you want it, especially if patients are actively undergoing chest compressions, right? So identifying those regional wall motion abnormalities in that situation would be important. And also in the early phase of an MI, you won't necessarily see the classic ST elevation. You might actually just see some peaked T waves, which I have to like do like a literature review on peak T waves themselves to see like how actually like sensitive and specific they are for pathology. Because I swear I see what I think to me are probably peak Ts, and they're just T waves, that happen to be a little higher, but they don't really mean pathology. But in any case, two reasons why I think looking for regional wall motion abnormalities, or at least being able to identify them, is actually pretty important. So because of that, this patient wasn't even mine. And I actually asked the provider who was taking care of the patient, the other ER physician, I was like, hey, do you mind if I like look at, do an echo while you're transporting the patient to the cath lab? And, they were still getting everything kind of like situated. We're waiting for carts to come down and see the patient. And I'm like, yeah, go ahead. So I took out my ultrasound and I saw this. Now, I'm assuming that most of you like know this, or are familiar with what a big pericardial effusion looks like, but that's what we're actually seeing here. We're seeing quite a large pericardial effusion. This is an apical four-chamber view over here, and then on the right side, we have a peristernal long axis view over here. We have atria, the left atrium, the mitral valve, the left ventricle, going into the LVOT, the aortic valve, the aorta, and then here's the RVOT. And over here, we have the left side of the heart and the right side of the heart. And we're seeing this hypoechoic fluid collection all the way around this very tachycardic heart. And just for reference, here are what no effusions look like. So pretty big difference here, right? And very unexpected. I mean, we didn't have any clinical suspicion of this beforehand. And there's no classic electrical alternans, right? The x-ray just showed an enlarged cardiac silhouette, which is often what you see with those big pericardial effusions. And we were worried that maybe this patient actually has tamponade as the cause of their symptoms, right? Because if things are being compressed, you could imagine that it could cause some ischemia as well. And so my next question, after we've identified this crazy effusion that we were not expecting, is how do we know if it's tamponade or if it's an effusion? Now, one thing that I have to definitely like, I'm a big stickler on this, and I'd be very happy to debate this with literally anybody. I think looking at the vital signs, specifically the blood pressure, is wrong. Like, I'll just say it. It's not like it's wrong sometimes. Like, it is wrong to look at that as the only marker to know if your patient's in tamponade. Now, the reason for that is because what does the human body do when it senses a shock state, or if it senses that the body is in any kind of distress? What does it do? It shoots off catecholamines, right? And what do catecholamines do? They make your heart rate go up, they make your blood pressure go up. So tamponade in and of itself, often, if you look at the cardiology literature, and this is in cath lab with like people whose job it is to tell you if it actually is tamponade or not, their literature actually says that the vast majority of patients that have tamponade actually are going to be normotensive or hypertensive, which is crazy. They're almost always tachycardic, unless if they're on some beta blockers or calcium channel blockers, almost always. But hypertension and normotension is the most common blood pressure in the setting of a patient with diagnosed tamponade. Now, what low blood pressure does mean when a patient has tamponade is that they have now completely exhausted all of their compensatory mechanisms. So you're basically waiting for them to crash before you diagnose it, which is ridiculous. There's no other disease process that exists that we wait for them to essentially be peri-arrest or to arrest before we call it a thing, right? Like, what about a pneumothorax? We don't wait until the patient has tension physiology before we put a chest tube in, right? If somebody has a potassium of 6, we don't wait until they arrest before we give them calcium. Like, I don't know why tamponade needs to be different than this. Now, I will say, at the bedside, there's really like, you have vital signs, you have your physical examination, you have your chest x-ray, which all of those can be specific, right? If you have that classic like Beck's triad, they can be specific. So if they're all present, like probably, the Beck's triad is was it muffled heart tones, elevated JVD, and hypotension, I think, is all three of them. But those are, I didn't put the data on here because there's just too much data to put on here, but they're obviously horribly insensitive, like orders of magnitude worse than a coin flip sensitive. If you have all three, there's a good chance your patient has that. So I wouldn't say highly specific. I'd say specific enough to remember, but not sensitive enough to rule out by any means. Now, the good thing is that most of the places that anybody works now, at least emergency department wise, does have the ability to access an ultrasound machine. And there are some findings that we can look for to help determine effusion versus tamponade. Now, before that, I mean, we can just like look at this heart right here. We don't need to know signs and symptoms. This looks like a very stressed out heart, right? I mean, you can see this big pericardial effusion all the way around this, and we're seeing this heart. This is kind of like a apical long axis view. It's not like a typical view of the heart, but we can see that heart just like waving around, really like struggling here. This is actually what electrical alternans looks like on ultrasound. So this obviously, like I'm looking at this, I'm like, this is a stressed out heart is probably tamponade. But there are some specific findings, if we're not sure, that we can use to help us out. So to diagnose tamponade, the first thing is there the presence of a pericardial effusion? Yes or no? Obviously, if there's not, it's unlikely to be tamponade, right? I mean, there's always exceptions to everything, but you know what I mean. Now, the first sign is actually going to be right atrial diastolic collapse. Now, I'd always have to pause here and like explain what I mean by right atrial diastolic collapse, because almost invariably, like when I say this in a lecture, or I say this in a podcast, people say, actually, it's a ventricular, it's ventricular diastole of the atrium. And I get that, but that to me is a little bit confusing to like say it that way, because diastole is when something is trying to fill. So what I mean when I say this specifically is that this is the diastolic collapse of the right atrium. Like the atrium has diastole and systole separate from when the ventricle has it. They're opposite, obviously, because if the ventricle is like in systole, it's like pushing stuff out. The atrium is filling, vice versa, right? So this is collapse of the right atrium during a diastole when it should be filling. That's when you have obstruction. That's when you get obstructive shock. That's the earliest finding, but it's a little bit kind of hard sometimes to differentiate. And then the other thing too is that you actually need to calculate over what period of time over the cardiac cycle. If you really want to be highly sensitive and specific, it's called the right atrial inversion index to figure out like what percentage of the cardiac cycle. So it takes more calculations. And honestly, I don't know if I'd recommend that, honestly. But it's thought to be the earliest finding. The, I think, easiest finding, as well as the finding that is most commonly discussed, is going to be right ventricular diastolic collapse. And again, this is when I say right ventricular diastolic collapse, I'm talking about diastolic collapse of the ventricle itself. And so that is a situation where you have the ventricle, and when it should be in diastole, filling, it's actually being compressed, right? Which, if it's being compressed, it's not able to actually do what it needs to do, which is fill. The next thing with pulsus paradoxus, it's not my favorite. And the reason why is because what you're using is pulse wave Doppler through the mitral valves and the tricuspid valve, and you're looking for differences in the peak velocities with respiration. And I don't like it for a couple of reasons. The first one is that if the pulse wave Doppler flow, if your gate is not right in the center, you're going to get an inaccurate reading, just not being in the center, irrespective of what the flow actually is. And if you happen to be off center, that even if it's the exact same flow going forward, that's actually going to give you vastly different peak velocities, because the flow in the center is going to be much higher. And this is, think about like the flow of like water, kind of like a river, right? The flow in the middle of the river going in a direction is going to be faster than the flow on the outsides, right? So if you're not directly in the center, you're going to have a much different velocity than if you're focused just on the edges. When patients have pericardial effusions, especially if they're in tamponade, the heart's going to shift. It's going to move around a bunch. And so just the movement of the heart itself can create this change in the velocity that might give you a false positive. It might actually give you a false negative. So I'm not a huge fan of these. Also, just the patient breathing moves the heart, even if they don't have a pericardial effusion at all. So you might get like different views or different readings of the peak velocity, even if there's no effusion, even if there's no tamponade. So it's not my favorite, but it's described as a thing that you can definitely look up. Not my favorite. My favorite is, of course, RV diastolic collapse. And then if I'm not sure, I want a little confirmatory kind of extra thing, I will look for the IVC. Now, the IVC is a surrogate marker of the CVP. So if the IVC is super plump, dilated on the ultrasound, then the patient likely has elevated central venous pressure, which would be consistent with an obstructive shock, which is what tamponade is. And if I think that a patient might have tamponade and I see a very small, skinny IVC that collapses 100% when the patient breathes, I'm less likely to think that the patient has tamponade. I'm not saying that like that 100% rules it in, rules it out. I'm just saying that this like pushes might help me push one way or the other, especially in cases where I'm not sure. So let's let's talk about what this actually looks like. So we see this is a kind of tilted apical 4-chamber view. And then over here, we have an effusion right here. So this is the right side of the heart here. This is the left side of the heart over here. And let's look at this right here. This is the right atrium. And we can see that this free wall is dipping. Now we're gonna slow it down, which I did this on Photoshop, but you can actually do this on basically any of the machines, even if you're using like a handheld machine like a butterfly. All you do is you hit the freeze button and then you kind of like cycle back and you can actually see when the valve, which is right here, when it is open and closed, and you can use that timing of that with the free wall itself to see exactly when the collapse happens. When the valve here, this is the tricuspid valve, when the valve is closed, this should be open. It should pop open when the valve is closed because that's when it's filling the atrium. So the valve is open, that's systole, and it collapses, that's great. If the valve closes and it collapses, that's bad, right? So if we look at this right here, tricuspid valve, notice when the valve is closed, that's when we're seeing that dip. So the valve is closed, that's atrial diastole. That's when it should pop open. We're not seeing that. We're seeing the opposite of that, which means that this is right atrial diastolic collapse, right? So that's abnormal. Now let's look at this one right here. This is a similar view. It's kind of a wonky view, but we have the right side of the heart right here. We have a pericardial effusion. This is tricuspid valve. We're seeing that fluid. It definitely, we're definitely seeing a good dip right here, right? We're seeing a dip of that right atrial free wall, but the question is this dip happening during systole or is it happening during diastole? We'll slow it down. We're going to pay attention to this right here, the valve, and we'll see if that collapse happens when the valve is open or when the valve is closed. And if we look at it over a couple of cycles, we can see that that dip is happening when the valve is open, right? Right there. And then it pops open when it's closed. And then when it's opened, it collapses. That's systolic collapse. That's right atrial systolic collapse. This is not tamponade. At least this is not right atrial diastolic collapse. This is right atrial systolic collapse, which can be normal. Patients who have pericardial effusions can also have a little bit of catecholamine surge for other things like sepsis, let's say, that causes that chamber to kind of collapse, right? So this is systolic collapse. Let's look at another view right here. This is a parasternal long axis view. I showed you a view of, it was different than this, but I showed you a view of this earlier. We have the left atrium, the mitral valve, the left ventricle, and then right here we have the right ventricle. Technically, it's the right ventricular outflow tract, technically, but we just call it the RV. We're seeing a circumferential pericardial effusion all the way around, and the question we have is, does this right ventricle, is it collapsing during systole or is it collapsing during diastole? Now we're going to slow this down and we're going to look at the mitral valve and the free wall of the right ventricle. And remember that tricuspid valve and the mitral valve, they open up at the same time. They're the same thing, right? So we can see that the valve, when it's open, we're seeing a dip of that right ventricular free wall, right? So look at the valve and then look at the ventricle right here. And if basically they're coming together, so opening and collapsing, that is ventricular diastolic collapse, which we don't want, right? Now, on this view, this specific view, the parasternal long axis view, we can actually have an extra kind of hint to help us know if this is diastolic collapse. And that's using something called M mode. So this right here, this clip, this is B mode or grayscale. This is like our regular ultrasound. And what we can do is we can use our M mode to actually look at what's happening along this line, any movement along this line over a set period of time, often about 6 seconds. So we hit the M mode, we actually can shift it over a little bit to make sure that it's over covering both the free wall over here and the tip of that mitral valve. And we are going to get like a waveform that looks like this. Now, in the y-axis, we have distance from the probe. And then on the x-axis, we have time. So this is movement along this specific line over time. And you see here, there's some depth markers here. There's more depth markers here. And these actually correspond with this. So we know right here, this is the mitral valve. That's just past like 10-ish centimeters. So we'll just say right around here. You see this little like two humpy thing right here? This is the movement of the mitral valve over here over time. Now, this is something that I always like, I don't know, I still find this quite interesting. And that's the fact that the mitral valve opens twice in the cardiac cycle. I actually didn't know that. I went through all of med school and didn't really know that, but it's true. This right here, this first opening, this is the E point or E wave, and this is the A wave. The E wave is early diastolic filling, which is the blood just based off of pressure differences between the atrium and the ventricle, just kind of moves because the ventricle has less pressure than the atrium. And this right here, this is the A wave. And that A wave corresponds with the actual atrial kick. So it's like the valve kind of flutters twice, it goes bop, bop, right? And so that's what we're seeing here. And so this right here, when this valve is open, covering those two peaks, that is going to be ventricular diastole. Okay, so that helps us know when diastole is. Now, if we look at this up here, this is the RV free wall, right about 5 centimeters. So we'll say this thing. This is movement of the RV free wall. So what we can do is we can kind of determine, is that dip happening in systole or is it happening in diastole? Is it happening when the valves are open or when the valves are closed? And we can see here, valves open, dip, valves open, a dip. So this is diastolic collapse. This is sonographic tamponade. And then if you need a little bit extra here, we can actually look at the IVC. This is both views of different IVCs. We have an IVC right here. This is liver. We have the probe in the sub-xiphoid, kind of like right in the middle sub-xiphoid area, the probe marker facing up, if you're in the abdominal setting. And we're seeing collapse of that IVC here. This is a low CVP. So if you have a patient with a pericardial effusion, you're like, is it tamponade or not? And we see this, it's probably not tamponade. Whereas if you see this right here, this is a very dilated IVC that does not collapse at all with respiration. And we know that the patient's breathing because this is basically the diaphragm right here. And we're seeing that movement. And because of that, this is a high CVP. So we see that same echo with this right here, high CVP. This is much more likely to be tamponade. Any questions on that? I'm going to move on to the next case here, but happy to answer any questions if you happen to have any. All right, I'll take your silence as you're good.
I'm going to take a brief pause here just to let you know that all of our content is on the coreultrasound.com website. That is Ultrasound Podcast, 5 Minute Sono, Ultrasound of the Week, Clip Bank, and we also have our courses page where we have the Core Ultrasound Fundamentals and Core Ultrasound Question Bank, where you have 3,200 questions with feedback, including narrated videos explaining the question. Check it out, and back to your video.
All right, our next case, 62-year-old female presenting with knee pain. Now, for this, I actually like this case. I don't know if either of you have ever been in a situation where you like almost get in a car wreck, right? It's happened to me occasionally where like I basically like I'm paying attention and someone swerves, and if I wasn't paying attention, like they might have hit me, and I see that and I get this like feeling, you know, in like my chest, like little fluttery, a little like heart rate goes up a little because like, oh my God, that could have been bad, but it wasn't. But oh my gosh, I could have missed something. That's how I felt about this specific patient. I had the same exact feeling. So what happened here is there was a patient that came and she'd actually been there 2 days before and was discharged with knee pain due to arthritis, basically, and came back 2 days later saying it hurt so bad that she couldn't walk. And I went and saw her. I said, okay, it's just going to be someone that maybe needs some medicine and some like follow up. Because, in the emergency department, arthritis pain, while it is important, it's not something that we would necessarily consider a medical emergency that we'd get all up in arms about, right? No trauma. Now, her story is that she basically has chronic arthritis. She's had it for years. She's had a relative who was in the hospital. She's been going back and forth a lot, been walking a lot. And she attributed like that increase in walking into why her knee was hurting so badly. As far as past medical history was arthritis, as well as had a history of diabetes, was insulin dependent, cholesterol and high blood pressure, some vascular risk factors. And I went and examined her. These are this patient's x-rays. It's pretty bad arthritis. Like there's like no space in between the bones here, right? They're like touching. We have some gnarly osteophytes over here. It's obviously a lot worse on this medial side right here. But she's still got some osteophytes. It doesn't look great on the lateral side. And then over here is a lateral view. And I looked at this and I was like, yeah, she's probably got bad arthritis. And one of the things that I'm trying to do a little bit more of is actual kind of more sports medicine, kind of regional non-nerve block pain control type things. And so I'm very excited to have started doing actual steroid injections for arthritis and for things like bursitis and stuff like that. I've actually been doing that a lot more in the ER. It seems to benefit patients a lot. So I'm stoked. And that's like a different topic about like doing injections and stuff like that. But I had this patient, I probably a couple of months ago would have just discharged her because vital signs were normal except for some tachycardia, no fever, blood pressure high. Physical examination showed a swollen knee. It wasn't red, it was not warm. She had a lot of pain with movement, but I'd kind of been biased with the fact that she'd been there 2 days before and she was discharged, and a very competent one of our physicians saw it before. And I was like, well, I mean, it's probably just that. Almost got anchored here. But what I did is I went with the ultrasound. I'm like, I want to learn a little bit more about how to like grade arthritis on ultrasound, how to identify it on ultrasound. This is the medial knee over here, and this is the lateral knee. And this is not like going to be like a comprehensive section on, looking at knees. But this right here, this very scraggly stuff over here in the joint, this, I'm going to pause this one and actually go to about here. So this right here, this like big V, this is the actual joint space itself. And really it should be fairly smooth, like fairly like kind of just go there and then come down. Same thing over there. But we see this like giant little like raggedy little peaks here. This is arthritis. This is what arthritis looks like. And we can see something very similar on this other side as well. Looks like arthritis. So I'd actually gotten the steroid from the pharmacy. I'd gotten a little bit of lidocaine because I wanted to give her some like immediate pain control, as well as giving her something for the arthritis for the next week or two. And so I was getting my landmarks down. I was actually sterile sheath on the transducer. I was like ready to go, but I just wanted to peek before I actually did my injection. And I identify this right here. This is abnormal. So what I'm looking at here is I have the probe, and I'll show you a picture of what that looks like exactly as far as probe placement. I have a linear probe. I have it just above, just cephalad to the knee in a sagittal orientation with the probe marker facing up. So this is towards the head, this is towards the feet, and this is like just a straight like sagittal cut right down the middle. And these are the structures that we're seeing. We're seeing the quad tendon, a couple of fat pads, a femur, and then a quite big effusion. Like this is a large effusion actually. That shouldn't really be there. I'm going to show you what kind of normal looks like. And this is more of a normal knee. We can see that there's a small bit of some hypoechoic stuff over here, just a small bit. This is probably a little bit of bursa or maybe even like a little bit of fluid in that joint, but nothing abnormal. This is what it should look like. And instead we're seeing this giant knee effusion over here. That's completely abnormal. And I 100% was not expecting this. I was just expecting to be, look kind of like this over here on the left. And then I was just going to inject and send the patient home. I was like, that's weird. Before I go on with the case, let's talk about how to look for an effusion. So this is going to be your placement here. And you're going to see, as we already talked about, quad tendon there. And then we're going to see the, kind of femur deep to that, and right deep to above the femur and deep to the quad tendon. We see that suprapatellar recess, which is where we would do an injection. Now, after we've identified in the long axis, I turn it into the short axis and then do my injection actually coming from a lateral to medial approach. And the reason I do it this way is because it's easier to see the needle in the needle's long axis. So when I turn it this way, the needle's coming basically like in this orientation right here, which it makes it way easy to see that needle just come right into that suprapatellar recess and do the injection there. As far as placement, you want to see it placed just like this. Just make sure that you have your machine kind of like in line of sight so that you can see very well what you're doing. And then you should see it like this. Now, this is the procedure on the patient. This is the suprapatellar recess. This is the effusion right here. This is femur. And then this is quad tendon up here. And over here on the left side of the screen, you're going to see a needle start to kind of poke through and get into that joint space. So this is performing the aspiration on that patient that had that big effusion. And as I kind of get into the joint space, I start aspirating. And as soon as I aspirate, and I have a mask on, I can smell it. Like I aspirate it and I can immediately smell pus. This is actually what came out of this patient's knee. It was just florid pus. Now remember, normal vital signs. I've seen there 2 days before and discharged with arthritis, history of arthritis, has arthritis on x-ray, has no redness and no warmth. And I pulled out pus from this lady's knee. Like this case, I would have sent her home if I hadn't thrown the ultrasound on there to do the extra thing of injecting. And if I hadn't found it, she may have like died. I mean, I'm catastrophizing probably, but like imagine like this would have gotten into her blood. It would have caused big problems at maybe she would have had to have like a knee replacement because we didn't catch this until like the fourth visit, you know? So this is like to me a really big plug to use ultrasound, not just in like the critically ill patient, you know, like the big trauma patient or the septic shock patient or the patient like our first case that had that huge pericardial effusion that came in as a STEMI. Patients with knee pain will benefit from using ultrasound on their knee pain. Any questions on that before we move on to our third case or comments? I'm ready. Don't apologize. I asked you.
When we talked about, so we had obviously the linear transducer, and you said you started primarily kind of vaginal cuts. You start at the top, more cephalad to the patella, and you want to identify those key structures. As far as like looking at patients with arthritic knees, obviously we're not going to be seeing. You can get effusion, sure, if you have pretty bad. Sure, but to the extent that you saw it, is there like specific, you know, how much are we going to see before we're going to start being more concerned about, okay, we really need to tap this knee? Because obviously maybe from the outside you saw that it was swollen, but it seemed like it probably wasn't very obvious that they had a large infusion from physical exam alone.
No, that's a phenomenal question. Like at what point do we like suspect it? Because we did not suspect it clinically. We did not suspect it based off of our physical exam. And the main thing is I looked at the other knee and the other knee had a little bit of fluid, but it was like a fourth of the size of that. If she had had equal fluid on either side, I might not have tapped. I might have just injected, honestly. But it would be very unlikely for her to have like, fluid around arthritis isn't physiologic, but I'd almost consider it like pseudo physiologic, like it wouldn't be that surprising of a small amount, but it's basically if I don't see that, if I see a much larger amount on the unaffected side, then I'm much more likely to think that the affected side, that is pathology. And that's one of like the best things, honestly, about musculoskeletal ultrasound in general, is that you have a control. I mean, patients can have problems in bilateral like extremities, but for the most part, if they have it on one side that hurts and they don't have it on the other side, I just suspect or I assume that it's pathologic. When you have patients that have, especially like inflammatory arthritis, like rheumatoid arthritis, you can, and I've actually recently discovered what my problem was. I've had 2 cases in the past year where I've tried to do a tap on something that looks obviously like an effusion to me. I can see my needle in that effusion. It's usually smaller joints like ankles. I can see the effusion. And I've seen it in the hips as well. I can see the effusion. I'm like pulling with that plunger. I have a short, stubby needle. I have a small syringe. Those are all like ways to try and get small amounts of fluid that are under a lot of they're viscous. Because if you have like a giant needle, it takes way too much force to pull that out. Just flow physics. But I recently read, actually saw a YouTube video because I was like, why is this happening to me? Like, why am I getting dry taps? And sometimes, especially in inflammatory arthritis, they can get synovitis actually. And the synovitis will look a lot like an effusion that is slightly complex on the inside. And the way that this video suggested differentiating was actually by throwing color flow Doppler on there. And then if you see flow on the inside of that effusion, it's more likely to be synovitis. And then if you don't see flow or only see flow on the outside of the effusion, then that's more likely to be an actual effusion. So just a couple of things to kind of like help out. All right. So our fourth case, we have a 24-year-old female and she has lower abdominal pain. This one's pretty obvious. I mean, when we have that, and she was hypotensive, she was not tachycardic, but she was hypotensive, looked sick, was like pale and stuff. This wasn't one of my patients. This was one of my providers at one of the hospitals I've worked at in the past. Amazing clinician. Learning about ultrasound, didn't really learn it very well in residency, but was excited to learn. Where I was at the time, I was the ultrasound director, so I was in charge of like faculty and resident education for this. And so he said, hey, I have a high suspicion of a ruptured ectopic in this patient. I tried to do an ultrasound, but I really couldn't see anything. I was wondering if you could take a look. I always say yes, right? There's never a time where like, no, I don't want to. For two reasons. The first one is I love ultrasound and I also like kind of like finding things. Like I don't want anybody to be sick, but if they're sick, like I want to be the person who finds it. And this was the first provider's ultrasound. And what that provider said was actually like, all I see is basically bowel and bowel gas. And this was the clip that they took. And I could see how that could be an issue, right? And let's talk about exactly like what things look like. Now, before that, I want to I got it and the patient had a high suspicion of a ectopic. And I usually in these situations, like when I identify an ectopic in a patient that's sick, that's ruptured, like I have not yet been in a situation where I call gyne based off of my ultrasound without a pregnancy test and say like, hey, their pregnancy test is pending, but this is a patient who missed their period or a known pregnant patient that has a large amount of free fluid in their abdomen. I'm concerned that they have an ectopic, and they never say, I don't believe you. They never do, at least not in my experience, which is great, which is what it should be. So what I did is the first place that I looked actually was not in the pelvis. I actually looked in the right upper quadrant first. Now, this examination, if you don't know, is called a FAST exam or Focused Assessment of Sonography and Trauma. And this was designed by surgeons in I feel like it was the 90s, like mid to early 90s maybe, that they developed this to look for hemoperitoneum in blunt or penetrating trauma patients, specifically in the abdomen. There's parts of it where you look for pericardial effusions and pneumothoraces as well, but we were looking at the abdomen. This right here, this is the liver. This is the kidney. These kind of like black kind of rays that are coming in. Those are rib shadows. You see the ribs up here, and they're causing like shadows because bone absorbs sound waves, so sound waves can't like get through it, so it creates a bit of a shadow deep to it. And we're seeing this right here. This is a hypoechoic fluid collection. This right here is fluid. Now, this might not be that scary in some patients. Like, let's say you have a patient with known ascites and you see this, no trauma to the abdomen. They're not distressed. They're just saying, like, I feel a little more distended. Might not be concerning, but in a otherwise healthy 23-year-old female who is pregnant, this is highly concerning. Why would she all of a sudden have abdominal pain, look sick, and have fluid in her belly? It's because of a ruptured ectopic. So as soon as I saw this, without confirming anything else, without looking in the pelvis, I told the charge nurse, said, hey, can you please call gyne because this patient has a ruptured ectopic. And then I went back and tried to look at the pelvis to see what I see. And this is the image I got. Mine is a bit lower than what that first provider's was, because honestly, most of the time when anybody who's kind of starting out looks at the pelvis for anything, usually they're a bit too high. When you're placing the transducer on the patient's abdomen, looking at the pelvis, you have to be basically like the lower part of the transducer. You basically have to be on the pubic symphysis, which is in of itself like a centimeter or two from the genitalia. So it's like uncomfortably low. So if you have any issues looking for anything in the pelvis, you're looking for ovaries, looking for a baby, looking for free fluid in the pelvis, looking for residual volume from bladder, all of that, if people can't see it, it's usually because they're too high. So I went a bit lower and identified a bunch of clot So that's what blood does, right? When blood is sitting in a space for a while, it's going to develop into clot. And clot looks different from hemorrhage. Clot is going to have this kind of mixed echo density thing. We see a little bladder over here. Here's the vaginal canal. I have the probe marker up. So we're in a sagittal cut. And then we see the uterus here. We're a little off center from the uterus in this clip because normally we like to see, the endometrial stripe right there in the middle. We are seeing some hypoechoic blood posterior to the uterus, and over here we have it posterior and inferior to the uterus right here. This would be the old pouch of Douglas, where you would expect fluid to accumulate. But that was what the provider had missed. The provider had missed understanding what clot looks like. Now, I will say that over here, this is bowel with some gray, dirty shadowing deep to it. But the fact that we can see directly through this without any shadowing, like we see over here, makes this not bowel, because air in bowel, anytime you have like air really in anything, it creates like a dirty shadow. Whereas something like a stone, like a kidney stone or a gallbladder stone or a bone, absorbs sound waves, so it creates a black kind of clean shadow. So black clean shadow is like a stone or a bone, and then a dirty shadow is usually air. And we had a learning opportunity. This didn't delay care at all, by the way. But I showed the provider and I was like, hey, by the way, this is clot. This is bowel. This is how you tell the difference. And we all learned. Now, I kept scanning and I was looking for that ectopic, and there it is. So it wasn't in the uterus. It was like on the outside, a little above the uterus. This little circle right here is the actual ectopic itself. So it's quite a ways away from that uterus that we see down here. It's a good case. Any questions or thoughts on that? Sick. All right. Now let's do our very last case. Another MSK one. This is one that actually, I'll be honest, it wasn't mine again. And I don't know. Like I think about this a lot, and I think that I'm never I'm always, when I see these cases where like someone else saw it and then I see it and uncover what it is. There's been so many times where I've had other providers do the same thing for me in a very nice way. Like, hey, like, have you thought about this? I'm like, oh no, like I didn't. I really appreciate that. And it helps with disposition of the patients. So in medicine it's a lot, like learning and remembering everything in medicine. Like it's hard, especially if we're not only seeing like that. If we haven't seen that thing in a couple of years, it might slip our minds, and this is kind of like a hybrid between those two. It wasn't my patient, but I also would not have identified this if I hadn't had the ultrasound with me. So this was a patient that actually presented with shoulder pain. It was a traumatic, fell off of it was either a dirt bike or a moped or something like that, hit the shoulder, like an anterior kind of like hit on the shoulder, had pretty bad shoulder pain, got a bunch of x-rays. The x-rays were all negative. And the patient said, my arm hurts too much. I can't move it. Like my shoulder is killing me. X-rays were fine. They were even read as normal by our radiology colleagues, which again, like this is not like a shamey thing. This is an education thing. I would have missed this as well. So just to orient you, this right here. So this is essentially a chest X-ray of its shoulder. It's like more focused on the shoulder. This right here, this triangular structure here is the scapula. We have the ribs. This is the clavicle. This right here is the acromion. This is the coracoid. This is the humeral head. This is the glenoid, which is where the humeral head sits in the scapula. This is glenohumeral joint. I mean, it looks in, right? I mean, we have this. It's sitting in where it should be. A dislocation does not typically look like this. At least a regular common dislocation doesn't look like this. And when we look at the Y view, we want the humeral head, which we're seeing over here, to be basically directly in the middle of this kind of Y here that's shaped by the clavicle and the acromion and the scapula here. So this was read as in, looked in. The patient had persistent pain, right? Said they couldn't move it. And so we brought the ultrasound in there to take a peek. All right. Now, just to tell you how to look, because this is one that's maybe a little bit kind of like tricky, we have the probe coming from the patient's back facing forward. All right. We're transverse. We find the scapular spine, and we just come out lateral to the scapular spine until we see the glenoid right here. And then we see the humeral head right here. So this is posterior and this is anterior. This is the humeral head in the glenoid, in where it's supposed to be. You can see as the patient externally rotates, you can see that movement of the humerus inside the joint. This is one that's in. Okay. So just to kind of reiterate the locations. Now, this on the right is the patient's shoulder. So in over here, right? This is all kind of like lined up. And then this is that patient's shoulder. Notice that the humeral head is much closer to the transducer than it should be, meaning it's posteriorly dislocated instead of anteriorly dislocated. Anterior dislocation is by far the most common. Posterior dislocation is uncommon on tests, on boards. It typically is someone who gets electrocuted or someone that passes out because it's an anterior force. So they hit their shoulder this way rather than falling backwards or falling onto their shoulder, which is the typical mechanism. This is a posterior dislocation. And then just to kind of orient you a little bit further, this is an anterior dislocation here. So here we have the glenoid, and then we have the humerus away from the transducer. And if we have the probe behind the patient, this is anteriorly dislocated because it's further away from the transducer. And then over here, we have the transducer in the back still, and we have the humerus towards the probe, meaning it's posteriorly dislocated. So posterior on the right, anterior on the left, and then we have one that's in the joint there in the middle. The patient was actually, the provider had ordered a CT already. And so we got the ultrasound, the patient went to CT, and you can see the problem here. The problem here is that there's a bit of a, I guess, a reverse Hill-Sachs right here. No, that would be a Bankart lesion, excuse me. That would probably be a Bankart lesion. I'm fairly certain, I may be misremembering. I think the Bankart lesion is on the humeral head and the Hill-Sachs might be. No, Hill-Sachs, I think, Hill-Sachs is the humerus. Hill-Sachs is the humerus. So this is a Hill-Sachs right here for sure. I'm like 65% sure that this is a Hill-Sachs. I'm pretty sure. I'll Google it later. I'll let you know. But in any case, you can.
I have to Google it.
Yeah, it's one of those things that's like on a test question, but it doesn't really like matter in real life, you know? At least not for us. I'm sure it matters for an ortho doc or a sports medicine doc, but not for us non those specialties. But you can see what the problem is, right? I mean, this like is just like stuck right in that, I think, Hill-Sachs deformity right there. Now, this patient, a lot of pain, right? We can definitely sedate patients to do this, and we often do. But I'll tell you, I mean, you all work in the same hospital I do, and sometimes it's kind of difficult to get a procedure that requires a lot. Um, it's kind of difficult to get nursing staff involved. We have RT there as well. We have to get the medicines. It takes 1 to 2 providers to get this done. It's very time intensive to do a sedation. So we can do that. But what I try to do instead is I actually try to do a nerve block or a joint injection to actually do this without sedation, right? So this is not the patient. This is actually baby me almost 10 years ago when I was in fellowship. I'm getting a block by my fellowship director just to show you positioning. You're basically coming through the middle scalene, which that's this muscle right here. You see the probe placement, and then the anterior scalene. And in the middle is the interscalene brachial plexus. You remember that that little weird fun diagram that you made in med school where you they come out with like the 3 like roots and then they kind of crisscross and do all this stuff, and there's like a Randy Travis mnemonic to remember what they're all called and all that stuff. This is actually it. It actually exists, right? And we can actually put some local anesthetic. We really, if we're just doing this for like a reduction, plain lidocaine or lidocaine with epinephrine, something like short acting, that's rapid onset, rapid off, works just fine. So this is my fellowship director, whose name is Matt Dawson. Rest in peace. No, I'm just kidding. He's not dead. He just doesn't do ultrasound anymore. He's like into sport, into like precision medicine and stuff like that. He's got a business called Wild Health that is doing great, and I'm very happy for him, but he doesn't do ultrasound stuff as much anymore. But this is him doing this procedure on me. You can see the needle tip here, and you'll see in a bit just some fluid start to get into this interscaling groove right here. This is back in 2015. We have different probes, different machines now that are a little easier to see, I feel like. So this is one that I did. This might have been that patient. I actually don't remember if this was like that patient or not. But you can see the needle here. You see the middle scalene, anterior scalene here. The brachial plexus sits in between the anterior and middle scalene. Here's the brachial plexus, and right here, this hypoechoic stuff is fluid. And you can see that that fluid starts to kind of push the brachial plexus away from the middle scalene. That's how we know that we're in the right spot. We can't really go on the other side because it's like scary to go anterior. We're coming from a posterior approach where there's no big blood vessels back there really. This is what an interscaling block looks like. And this was the patient's before, and this is the patient's after. So we can see here that this is reduced. We're seeing a bit of an effusion in here, which makes perfect sense. I mean, it was traumatic. The patient had a bunch of pain and stuff. And so of course there's going to be some hemorrhage inside the joint. I imagine that there's probably 0% of patients with any kind of a shoulder dislocation that don't have a concomitant rotator cuff injury. Like, I don't know how that can happen because the rotator cuff needs to be stretched out in order for that joint to like pop out. So they often are going to have still issues afterwards. So this is not like, great, you're like fine, you don't have to worry about it. Like, and I remember talking to the patient about it and being like, hey, we found it and we fixed it, but it's going to stink for like weeks to months, just so you know. Like, you're going to need recovery. You might need surgery if your rotator cuff's actually torn and stuff. But we at least fixed this more acute problem. And then if you wanted to see the before and after x-ray, you can see here that it looks the same almost, right? You can almost like argue that, yeah, they're both in place, but you see here how there's a little like kind of bump going into the joint. That is actually what normal is. This right here, you might say it kind of looks like a light bulb. This is called a light bulb sign, which is pathognomonic in a shoulder for a posterior dislocation because it's actually the humerus is actually sitting kind of rotated. I'm fairly certain I'm trying to think. Hold on. I think how it comes out. I think it's externally rotated. So we're actually looking at the bump, looking at us instead of to the side. So that's why it kind of looks like a light bulb versus this little like bulgy thing on the side. So this is normal or reduced. And then this is what a posterior dislocation looks like. How do we feel about that one? Do we feel okay?
Yeah, that's a tricky one. And Kenny and I looked at a shoulder the other day more for our fun, our learning.
Learning is fun.
And yeah. It was just a patient who had some, they had the calcification of one of the biceps tendon on an x-ray.
Nice.
And so we wanted to look and see if we could see it. And so we were able to like identify not the subscapular, but the other one that starts with S,
the supraspinatus.
Yes, thank you.
Yeah.
Supraspinatus. Mm-hmm. And we actually saw calcification more on the supraspinatus than the biceps tendon, but I wasn't sure. I'm not sure if we did the best positioning to look at the biceps tendon. I don't know if you have any tips for identifying those on ultrasound.
Yeah, no, I sure do. I will actually, let me do that right now. I can actually send you a link to the shoulder exam that I have that can help identify all that stuff. So let me just do that before I forget, because as you probably realize, based off of the fact that you got the alert for this like an hour ago, I am very forgetful. And yeah, so I'll send this to you all right now. So that's all my MSK stuff. And you'll see that there's a shoulder dislocation, a rotator cuff exam, and then a non-rotator cuff exam. And probably all of those would be good to like review. Now we have the transducer right here. And then the way that we do the shoulder exam to start, and you'll see it on that video, is you basically place it. Actually, what's that doing open? Close. We actually put this right here, just on top of the scapula right here. And what we can do, actually, can I show you guys something really cool? I'm like really excited. I'm like working on this like setup. Hold on one second.
Sure.
Thanks. I just got to maneuver this just a little bit because I have it set up for something else right now. Okay. Is it this shoulder? No, it's this shoulder. Okay. Are you ready? I'm like so excited. Ready? 1, 2, 3. I changed cameras. Isn't that cool? Hi.
Oh, that's pretty cool.
Hi. Okay, so let's look at my. All right, let's look at my shoulder. We'll look at this side's easier. So you start off with the patient externally rotated like this, and then kind of palm up, and then you place a transducer with a probe marker facing towards the patient's right, typically right about here, like right in the middle. And the first thing you do is you're going to identify the biceps tendon in the bicipital groove, and then you kind of like go up and you can look at everything, and then you place the patient in the modified Crass maneuver, which is hand kind of behind the back, and that puts the supraspinatus from basically underneath the acromion. It'll move it to be now where your probe is, right? Because we're just like rotating it from behind. Now we're rotating it forward, and we can see it a lot better that way. So that's the supraspinatus. And the subscapularis, typically, that's the one that you see with just like the arm like this. But I start off usually with looking at the biceps tendon because you want that to basically be anterior to start your examination. Because if you're internally rotated or even like externally rotated, you might not be able to identify the right landmark. So it's almost like to identify that you're in the right spot, basically. That's actually like kind of like what you're doing by identifying the bicipital, the long head of the biceps tendon in the bicipital groove first. So I start there. Now, I will say that there's a chance, and I don't know because I wasn't like there's a chance that when you, the x-ray, when the x-ray saw calcifications of the tendon, that was in the biceps tendon because, you have a long head and a short head. The long head is the one that like attaches right here. The long head of the biceps tendon, the supraspinatus and the subscapularis, they all connect in one spot, which is called the rotator cuff interval. So often you get to that spot and you're like not sure what structure you're looking at. And in fact, I look at my clips like early on, and I actually labeled some as rotator cuff tears when it was just the rotator cuff interval. But it looked like a tear because the fibers aren't all going in the same location, right? So you see fibers and then a fibers, and then that is what a tear looks like in the right location, right? I do talk about that in those shoulder videos. So this is just kind of like to have you like think about those words when you hear about them, because I have good examples of exactly like what they look like on those videos. Cool beans? No worries. And then also like with the Hill-Sachs lesion. So there's a Hill-Sachs and a Bankart lesion. One of them is on the glenoid and the other one is on the humeral head. And that was what I was confused about. So I think the humeral head one is the Hill-Sachs, and which is on the humeral head, and I think a Bankart is on the glenoid. They're not both on the same structure. That's the word I was trying to find. You guys ready for like one last case? How do we feel? Are we feeling okay? All right, I'm gonna take that as a yes, probably. But yeah, great. Stop me at any time. All right, our last case, we have a 35-year-old male that presents with shortness of breath. I mean, we get this a lot. Like the past couple of years, we've gotten this like incessantly, right? We have somebody come in, they have normal vitals, and they're like, oh, when I see these patients and I do my workup and it's negative, I often think like I don't get like upset or frustrated because I often think like, how like amazing is their life that this is the worst thing in their life, like being a little short of breath because they have a cold. Like that's amazing. Like I would love to be in that situation in my life one day where like me having a cold is the worst thing going on, right? Anyways, I'm digressing. This was before COVID. And this patient actually had a history of IV drug use in the past. We actually had a lot more of that where I used to work in Kentucky. Here I feel like it's all meth. But in Kentucky, there was a lot of IV, like heroin use actually. And this patient had been to multiple urgent cares, had been diagnosed 2 courses of like got a Z-Pak, and then I think got like some kind of a cephalosporin the second time around by a different provider. Got a little bit better while taking the medicines, and then like got bad/worse after the antibiotics stopped. So it never really seemed to resolve. So it was there for evaluation. Now, what I usually do when I have kind of like a high enough suspicion that they might have a pneumonia, which is what I thought the patient had, just a bacterial pneumonia, I'll do an ultrasound of the lungs and actually look for it. And this was the patient's lungs. Now, and this was actually all over. Now, what we're seeing here is we're seeing an artifact. So this right here, this is the pleural line. These vertical, lines that start at the pleural line, they extend all the way down to the bottom of the screen, and they're moving as the patient breathes. These are called B lines. These sonographic B lines are the same thing as curly B lines that we see in an X-ray. They don't always mean like fluid necessarily. They actually are indicative of increased density in the lungs, which often, especially in the setting of like volume overload, like in heart failure, it often is fluid, but it could be from anything. It could be from a pulmonary contusion. You can see it in atelectasis. You can see it in an infection, because inflammation is like pulling water into that area and creating like little areas of atelectasis, which is causing increased density, which causes the beelines. We're seeing a couple other things too. We're seeing this right here. It's very hypoechoic with the structure coming in and out of view. This is a small pleural effusion. And this, I don't remember. Well, I was going to say I don't remember what side it is, but I labeled it luckily. So this is the right side. So that means that this right here is the diaphragm, the slightly more hyperechoic kind of border of it. And then deep to it, that's actually going to be the liver. And we're seeing another thing that is, see this little dip right here, this hypoechoic little, like very small consolidation. I don't like the nomenclature, but it's what we call it. We call it a subpleural consolidation. And we call it this when it's less than 3 centimeters in diameter. The reason I don't like the nomenclature is because like everything is subpleural. Like anything is subpleural. So I don't know why we call this one subpleural and we don't call the rest of them subpleural. So I don't know. I like went through this phase in my life where I was calling these small pleural consolidations because it actually makes a lot more sense to me and the abbreviation still fits. But I don't know. It's like a lot of things like where I don't fight it. Like I used to get almost 10 solid years, I resisted saying POCUS because I think it's ridiculous. Like it just sounds so silly to call it POCUS, but everybody uses it. So I'm just like, ugh. And so like I'll say POCUS. You can catch me saying POCUS every once in a while, even though I don't like it. Same thing with this. I still, even though I don't really like it, I call it a subpleural consolidation. This is normal just for reference. So we have a rib here, rib shadow, rib shadow. We have the pleural line up here. We're not seeing B lines. This is an air-filled thorax. We're seeing A line. So this is an A line here. This is another A line here. This is what an air-filled thorax looks like. And you see how different these are, right? So this is a bunch of B lines, a subpleural consolidation, and a pleural effusion. So there's a lot of things going on. And whenever I see that, I think that's more likely for it to be an inflammatory process, right? And especially the patient had signs and symptoms concerning for pneumonia. And if someone has a bacterial pneumonia, it's going to be stuck in one lobe of the lung, one area. It's going to be look like a giant consolidation. Like you'll see basically lung tissue. Like you'll be able to see something called dynamic air bronchograms with bacterial pneumonias, where you actually get to see like pus moving in the airways, like back and forth, like bubbles moving back and forth. This small thing is much more consistent with a viral pneumonia or something like a viral pneumonia. And this was before COVID, by the way. So like we weren't really thinking viral pneumonia because the patient seemed a bit sicker than that. Now remember I said the patient had a history of IV drug use and then had these kind of like patchy areas throughout his lungs that are showing this kind of inflammatory process. And so when I see this, I think, could this be any of these things, right? We already talked about them. Oh, it could be pulmonary embolism as well. That can cause them. Could be cancer, but all these are like, cancer is less likely because you don't see that inflammatory process around cancer. But in any case, this is the differential diagnosis for a subpleural consolidation. And look at the penultimate one. That means second to last, by the way. I learned that word the other day. The penultimate one here, the septic embolus. This is what the patient had, is actually septic emboli from endocarditis from their IV drug use. This is an apical 4-chamber view. This is the mitral valve. This is a tricuspid valve. Look at that giant booger on that valve. This is pretty bad endocarditis. This is normal just to like, so that you know what it should look like. We're quite specific for endocarditis. We're not sensitive transthoracic. Even transesophageal, like it's pretty good, right? But it's not like 100% sensitive. Usually the gold standard is blood cultures and suspicion, honestly. But it does pretty good, especially if we happen to identify it. So it's not something that we're going to see very commonly, but hey, this was just 5 cases of things we might not see every day. Some of them we might see, right? That MSK stuff. I try to do like big to start with, big tamponade, and then end with a heart thing, endocarditis. In the middle, put in some stuff that we're more likely to see, which is like the MSK stuff. And that's what I got.
Hopefully that was helpful for you all. I look forward to hearing what you all think. Make sure that you check out our core ultrasound question bank and core ultrasound fundamentals. They are a great way to track your own training, and we actually sell this to residencies to be able to track their residents' training. The whole reason we did the question bank is because we were realizing that some of our residents weren't seeing a good amount of pathology. Like they were scanning, but not really being able to identify pathology because
maybe the month they were on was like not a typical like a lot of trauma, they wouldn't see it. So we created this 3,200 questions for you to go through. And it's not a long process. It's just, is this a pneumothorax or is this not a pneumothorax essentially? And all the 3,200 questions have video narration. So they all have explanations as to why this thing or whatever it is or isn't a pneumothorax or isn't pleural effusion, for example. And then we also have a course that I designed when I was the residency director at the University of Kentucky. I was like, we need something. And I created this online course and had it for the residents and decided, hey, like we should probably, if I needed it, other people might need it too. And so created it. We also have other courses online that give a bit more comprehensive look. If you want a year-long fellowship where it's like super comprehensive, we actually meet one-on-one, like I will look at your ultrasound clips, de-identified ultrasound clips. We'll walk you through some ways to improve it, what I think certain pathology was, or we can just chat about anything. I would check out the Ultrasound Leadership Academy. I'm the director of the Ultrasound Leadership Academy. It's a nonprofit where our goal is to help people with a little more comprehensive of an education with ultrasound. And it is the curriculum that I made for the residents at the fellowship that I had and the fellowship that I'm going to start at Temecula Valley Hospital, not this coming year, but the year after that with Mike Macias, which very excited about. A lot of things in the pipeline here. Check out Ultrasound Leadership Academy. Check out courses.coreultrasound.com. I look forward to hearing from you and happy scanning.